Awesome. Thanks so much, Sharon. Thank you everybody for being here. And, as you all know, this is a follow-on session because many people did not get the opportunity to give public comment at the HICPAC meeting, and many people still would like to give comment. I'm going to go ahead and turn it over to our first commenter, Lisa Brussel.
Hi, my name is Lisa Brussel. I'm an industrial hygienist and research consultant with the University of Minnesota Center for Infectious Disease Research and Policy. While I understand that the work group is following a standard process for reviewing and recommending revisions to the 2007 isolation precautions guidelines, it is clear to me that the work group needs more expertise and input from scientists and other stakeholders in reconsidering the guidelines. The presentation from the work group in June and today's discussions about standard precautions highlight how much the work group is missing in terms of other perspectives and input. The work group and CDC would benefit from a more open, inclusive, and consultative process right now, because you are missing some very important key information and insights. The historical perspective on standard precautions highlights how important it is to step outside of your comfort zone. The OSHA bloodborne pathogen standard revolutionized the management of blood and sharps in healthcare settings. The OSHA TB standard encouraged the development of CDC TB guidelines. What we've learned from COVID-19 should not be treated as something unusual or unexpected for respiratory infectious diseases, but as an opportunity to rethink the overall approach to aerosol transmissible diseases. COVID-19 highlighted the importance of considering transmission from asymptomatic and pre-symptomatic transmission, but SARS-CoV-2 is not the only respiratory infectious virus where pre- or asymptomatic transmission may be possible. What does this mean for standard precautions? There are interventions such as improved local exhaust ventilation and patient source control that should be encompassed in the standard practices or core practices for aerosol transmissible diseases. While I applaud the work group in thinking more carefully about the air mode of transmission, you need to move beyond the far and close range and large versus small particle definitions to encompass the full range of aerosol inhalation at all distances in shared spaces. As you have heard from many commenters today, the work group needs to carefully rethink your assessment of respirators versus surgical masks. There is no science that supports the use of a surgical mask for its original purpose in limiting surgical wound infections or as its newer use as personal protective equipment. CDC and HICPAC have an opportunity right now to be innovative, creative, thoughtful, and future thinking. I urge the committee and agency to consult widely right now with public health professionals about lessons learned and where we should be going next. A letter from 900 public health professionals calling for more transparency and consultation should be a sign that the committee is not going about things the right way. Why ignore us when involving us in your decisions would make the world better for all of us? That is the true meaning of public health. Thank you.
Thank you for your comment, Lisa, and we'll hand it over to Greta Fox.
I'm a nurse practitioner with the World Health Network speaking as a patient advocate. The idea that it's acceptable for healthcare facilities to choose not to mitigate against airborne pathogens because we have population immunity and we have the tools is false. It's in direct opposition to our directive to first do no harm. As well, the idea that only those at high risk need to be concerned is false, since the majority have a condition that puts them at high risk, and because repeated infections are inevitable without mitigations and ultimately cause immune dysregulation and other outcomes, which ultimately place us all at high risk. To protect patients from exposure to a deadly disabling BSL-3 pathogen, it's essential that all infection control policies be guided by a core understanding of the basic and inescapable facts. COVID is airborne. It spreads by inhalation of infectious aerosols at close and long range, which can float, spread, and linger in the air for hours. Improperly engineered indoor air increases the likelihood of both close and long range transmission and in previously occupied spaces. Respirator masks provide superior protection against inward and outward flow of aerosols, while surgical masks, which are largely not modified to be worn tightly fitted in practice, are neither intended nor suitable for respiratory protection. One-way masking is not as effective as universal masking. 40 to 50% of transmission is asymptomatic. The virus is constantly mutating to become more transmissible and more evasive of vaccines, tests, and treatments, which are not equitably distributed. And Dr. Fauci says that population or herd immunity is unattainable sustainable under these conditions. With these core facts in mind, it is obvious that mitigations to protect patients and staff from inhalation exposure must be based on one simple concept: don't share unfiltered air. Universal precautions must be put in place and supported and enforced. Staff must wear respirator masks in all areas where patients pass through or are treated. Patients must be provided with respirators before entry or be allowed to wear their own equivalent PPE with greeters trained accordingly, and indoor air quality must be brought up to infection control levels. These are perfectly manageable mitigations requiring only the will to implement them. Without them, patients are forced to do a risk assessment every time they seek needed care to decide if it's worth the risk of contracting COVID. And some patients have no choice. Those who can't forego care are unconscious, debilitated babies, small children who can't mask effectively. Their right to equitable access to safe care has been traumatically stripped away without their consent. HICPAC, it's okay to say we made some missteps during an evolving complex situation, but the data has become irrefutable and it's now time to change course. This is HICPAC and CDC's opportunity to come out on the right side of history, but please don't keep forcing patients to beg for their lives in order to receive treatment in a safe and caring manner, knowing they can be told we won't because we don't have to. And please don't keep forcing patients to choose between certain and likely adverse outcomes when really a mask is such a small ask.
Thank you so much. I'm going to hand it over to Jamie Cleland.
My name is Jamie Cleland, and I'm a resident of New York, speaking today as a private citizen. I want to encourage the committee today to adopt strong protections from airborne infections in healthcare settings. I have been following news about COVID-19 around the world with great concern. In Okinawa, Japan, Dr. Hiroshi Yasuda reported this summer that emergency patients were unable to find care even after visiting 7 or 8 hospitals. He described the situation as a medical collapse. This emergency in Japan followed the country's decision this spring to take fewer precautions against COVID. There are 2 parts to this crisis: the number of infected patients and the lowered ability of the medical system to provide care. A recent report from the United Kingdom shows that doctors themselves are no longer able to work as they did before due to continuing symptoms from their own COVID infections. Many of these infections were acquired in their own workplace. With more and more sick patients and fewer doctors and nurses, it is imperative that we do everything we can to prevent airborne infections in medical settings here in the United States. This includes steps such as N95 or better respirators, along with ventilation and HEPA air purification. Reports from Australia show that more than 1 in 10 people who acquired COVID during a hospital stay died of their infection. The risk of becoming infected in this way is leading me to delay healthcare for other conditions. I had surgery during the fall of 2020 and was grateful for the precautions taken by my medical team. In the summer of 2023, I am no longer comfortable visiting the doctor for routine or even urgent care, let alone surgery, in an environment where patients and even doctors are unmasked. Let's learn from what we can see about the pandemic around the world. I ask the committee to first do no harm and to prevent the airborne spread of COVID in medical settings for the protection of patients, workers, and the entire healthcare system by adopting the highest standards of protection. Thank you for your consideration.
Thank you so much. And now we'll continue on. Naomi Baryam.
My name is Naomi Baryam, and thank you for this opportunity to add my voice and expertise regarding updating guidelines for isolation precautions. I am Director Emerita of Mother's Milk Bank Northeast and past president of the Human Milk Banking Association of North America. I have worked in maternal and child health for 35 years as a researcher, educator, and advocate. Since 2006, my work has focused on our most vulnerable citizens, premature and sick babies. Each day, parents and healthcare workers of many disciplines work tirelessly for the lives, growth, and development of sick and premature babies, over 10% of the births in the US. Some of these babies are born at less than a pound, as much as a can of corn in your pantry. Most are bigger, a whopping 3 or 4 pounds, quite a bit less than a bag of flour. All babies are born with immature immune systems, making them vulnerable to diseases in the environment. This is even more true of preterm babies, whose body systems and organs are not fully developed. It is well established that COVID can cause long-term irreversible organ and immune system damage. For one example, COVID can cause lymphopenia, a depressed immune system in immature and preterm infants as well as adults. Some babies spend weeks and even months in the hospital before they are strong enough to go home. Hospital NICUs work hard to protect babies from pathogens that have short and long-term harmful effects, including death. We know that COVID and other viruses are airborne and that surgical masks, most commonly used in hospitals, are not designed to protect against transmission of airborne pathogens. The numerous protections of the NICU are compromised if providers, hospital staff, and guests bring viruses from the outside and spread them in the NICU to one another and to the babies because of ineffective masking. Hospitals and other healthcare institutions look to the CDC and HICPAC for strong leadership and guidelines that reflect cutting-edge knowledge and research. The National Personal Protective Technology Laboratory at NIOSH, the U.S. Department of Labor's OSHA, and National Academies of Sciences Standing Committee on Personal Protective Equipment for Workplace Safety and Health have sound, well-researched guidelines and scientific information on workplace safety precautions for airborne diseases. The information that they can provide include recent research on airborne transmission and its mitigation. These should be the foundation of HICPAC's updated recommendations for hospitals and healthcare settings. Thank you.
Thank you, Naomi, and I'll hand it over to Dorothy Wigmore.
Thanks very much. My name is Dorothy Wigmore. I'm a longtime occupational hygienist and ergonomist trained to protect workers from airborne and other hazards. Prevention and precaution ground my professional ethics and activities to eliminate and reduce hazards before they enter or affect someone's body. It's the public health approach, since occupational health is part of that broad field. As a Canadian, I'm very conscious of the CDC's influence here and elsewhere in the world. Transmission truth matters. Getting it right leads to the right protections for workers and the rest of us far beyond the US borders. Today, I focus on the resistance behind droplet dogma, what counts as evidence, and lessons others have learned. It seems HICPAC is ignoring the historical misunderstanding about aerosol and airborne transmission of viruses. The 2021 paper by Catherine Randall and others about that history is essential reading to understand why infectious disease specialists describe that transmission incorrectly and very differently from occupational hygienists, aerosol scientists, ventilation engineers, physicists, chemists, and other scientists. Others looked at historical reasons for that resistance in this pandemic in a 2022 paper. There are many long-standing and recent studies with the same message. There is strong, consistent evidence that common viruses, including SARS-CoV-2, spread by airborne transmission. As one set of authors recommended, the public health community should act accordingly and without further delay. The Public Health Agency of Canada actually sort of did that in late 2020. Earlier than the CDC, if I remember correctly, and more openly. What counts for evidence is a key factor. Based on his lifetime achievement oration at the 2023 International Epidemiology and Occupational Health meeting, David Kriebel wrote that it is simply unethical to consider that only randomized controlled trial evidence and reject as flawed all other studies. If we accepted this view, we'd be unable to protect workers from literally hundreds, if not thousands, of occupational hazards. As an occupational hygienist, I believe the job is to try to answer the question, do we know enough to act if X causes Y? Worker protection requires effective action. It's unethical and inappropriate to rely on Cochrane reviews done by those apparently devoted to droplet dogma, a definite conflict of interest, that insist only RCTs matter. Lessons have been learned in this pandemic. Dr. Anthony Fauci talked about the need to be humble in the context of learning about aerosol transmission. The WHO's chief scientific officer left her post in 2020 regretting the organization did not forcefully say an airborne virus. This is an airborne virus, much, much earlier. There's also the Lancet 2022 Commission on Lessons in the Future of the Pandemic that said costly delays in acknowledging the airborne transmission were a significant factor. 17 years ago, Justice Archie Campbell dove into the tale of two cities and the infectious disease occupational hygiene divide behind his mammoth 5-volume report about SARS-1 in Canada. Key paragraphs include, if we don't learn from SARS and we don't make the government fix the problems that remain, we will pay a terrible price in the next pandemic. And we have. Thank you.
Thank you, Dorothy. I'm going to hand it over to Karina Halevi.
Hello. My name is Karina, and I'm a PhD student in Language and Information Technologies at Carnegie Mellon University in Pittsburgh, Pennsylvania. I'm also an aspiring educator in computer science, as well as an arts administrator, choreographer, and dancer. And as an undergrad, I also served as a teaching assistant for 5 semesters. So I've seen firsthand the impact of airborne diseases like COVID on the performing arts and education spaces. I would like to comment about universal use of respirators, isolation, and ventilation for infection control. As a grad student, I'm worried about my ability to even get through my degree, given the complete lack of COVID precautions ensured by the CDC and then reflected at my institution. I've heard of 22-year-old PhD students having to quit because after they got COVID, they couldn't even walk up the stairs. COVID causes long-term vascular damage, heart damage, and brain damage. I'm especially appalled at the dropping of basic precautions in healthcare settings, making it unsafe for me to seek medical care. Despite never removing my respirator outside my dorm room, I got COVID from my sink mate because my undergraduate institution had a policy of forced infection after they got rid of isolation housing. And since then, I've had debilitating fatigue, a chronic cough, chest pain, indigestion, and excruciating headaches every single day since March 2022. I haven't been able to get medical care to see these issues because healthcare facilities have been unsafe, and every day I have to go to class and work and choose between my health and my career. Several of my classmates also now have long COVID because their initial exposures were to completely asymptomatic people. The CDC needs to make it clear that healthcare workers must wear high-quality, NIOSH certified N95 or higher masks, mandate HEPA ventilation in all healthcare facilities according to ASHRAE standards, and strengthen its isolation guidance for COVID, which is over 10 days with consecutive negative tests to exit isolation. The evidence review on N95 respirator and surgical mask effectiveness was also flawed and needs to be redone with input from scientific researchers and experts in respiratory protection, aerosol science, and occupational health. I urge the HICPAC and CDC to open further meetings for public comment and take the most basic precautions against infection with an aerosolized, asymptomatically transmissible BSL-3 deadly and disabling virus in their healthcare facilities. Thank you.
Thank you so much. Moving on, Hiroko Kawana.
Hello, my name is Hiroko Kawana. I'm 32 years old and I live in Alameda County, California. As a member of the public, I am very concerned about the lack of respiratory protection included in the standard precautions discussed at this meeting. We are in an airborne pandemic, and the CDC itself published a study showing that N95 respirators are significantly more effective at preventing airborne transmission than procedure masks. Yet most healthcare facilities are only using procedure masks, or worse, no masks at all. The CDC has also recommended 5 air changes per hour in all occupied indoor spaces, yet ventilation information is not available at healthcare facilities. I would like to share my experience. I have a condition that causes severe urinary incontinence, and my urologist said that the only treatment option is an inpatient surgery. However, I'm not able to safely get this surgery because the risk of getting infected with COVID during the surgery or recovery. I am not able to protect myself while unconscious under anesthesia or while eating, drinking, and taking medications during the subsequent hospital stay. The hospital defers to the CDC and does not use effective respirators or have ventilation information publicly available. I am seriously considering if continuing to suffer soaking in my own urine 24/7 is a better option for me than getting unsafe care. I have had other discouraging encounters while seeking healthcare as well. I have had an oral surgeon operate on me without an N95, despite saying he would wear one. I am having trouble finding primary care, physical therapy, and sleep studies where I am not exposed to potentially contagious staff or patients. I am relatively lucky. My medical conditions only cause discomfort, pain, and loss of dignity. I am not facing death as some patients are, and I can only imagine how terrifying it is for them to attempt to get healthcare. I urge HICPAC and the CDC to require universal masking with N95s or better, and ventilation and filtration in all healthcare facilities. Healthcare is a human right, and nobody should be risking illness or death in order to access it. Thank you.
Thank you. Jonathan Fluxman.
Thanks very much. Thank you for the opportunity to comment on your forthcoming recommendations to the CDC on infection control policy. The CDC is a world-renowned body and its policies influence many other countries' infection control authorities. I'm a retired general practitioner in the UK where we follow very similar infection control policies. HICPAC's proposals are deeply flawed for the following reasons. One, there is failure to recognize airborne spread as the predominant route of transmission of SARS-CoV-2 and other pathogens, and therefore to recommend protections against this in healthcare, i.e. N95 masks, air filtration and ventilation, as well as UV light. Testing of healthcare staff and patients is essential, as is sufficient time off work for staff to fully recover. Two, there is overwhelming international scientific consensus that SARS-CoV-2 is primarily an airborne virus. The multinational Delphi consensus statement in Nature in November 22 reaffirmed that, quote, SARS-CoV-2 is an airborne virus that presents the highest risk of transmission in indoor areas with poor ventilation. 100% of the almost 400 experts endorsed this view. Super spreading, the hallmark of airborne transmission, is well known to have occurred in hospitals with other coronaviruses, SARS and MERS. HICPAC has ignored all this. Three, the membership of HICPAC is exclusively from the biomedical sciences. There are no ventilation engineers, aerosol scientists, occupational hygienists, or other experts on respiratory protection on the committee. Cholera was not stopped by doctors, but by water and sanitation engineers. There are also no patient or community voices, for example, from disability and clinically vulnerable groups. Four, the evidence base for HICPAC's recommendations is highly selective to ensure the continuity of previous policy, i.e. droplet AGP precautions. The studies relied upon are flawed and subject to trenchant criticism, including the recent Cochrane mask review. HICPAC also ignores the widespread and decades-long use of respirators to protect workers and a range of other industries against inhaled airborne hazards. Five, in common with infection control in the UK, HICPAC fails to evidence its favored droplet AGP theory of transmission. While ruling out evidence for airborne transmission, you simply revert to droplet theory by default. Where is the evidence to support droplet spread and risk from so-called AGPs? In a meticulous historical analysis of disease transmission research, Jimenez et al. Found, quote, no direct evidence for large droplet spread as the route of transmission for any disease. Studies show no additional risk from AGPs and far greater aerosol generation by ordinary activities such as coughing or talking. So poor is the evidence base for AGPs that the Lancet recommended in 2021 abandoning the term altogether. Yet HICPAC continues to endorse AGPs in its policy. Six, a scientific approach to policymaking must also include review of existing practice based on that policy. In the UK, at least 14,000 patients have died from hospital-acquired COVID and 70,000 or more infected in hospitals each year. 2,100 health and social care workers have died of COVID-19 in the first 2 years of the pandemic, and hundreds of thousands have acquired long COVID. Nosocomial infection rates of COVID-19 are running at 30%. Droplet-based precautions have been a disaster for infection control, yet this fails to prompt comment, let alone policy change. Finally, point 7, many people are now afraid to go to hospital, especially those who are clinically vulnerable, because healthcare is not safe. A survey by clinically vulnerable families in the UK found that 91% of respondents said they had or would delay or cancel healthcare appointments because of the lack of protections against COVID-19. People are being deprived of essential medical care because your policies place them at risk. Along with thousands of others, I urge HICPAC to follow the science, amend your policies to recommend airborne precautions as standard as a matter of urgency. References to the above facts appear below. Thank you very much.
Thank you, Jonathan. Just a gentle reminder to everyone to try to confine your comments to the 3 minutes available for each speaker. I'm going to hand it over now to Kathleen Turris.
Hello, my name is Kathleen Turris. I'm a volunteer with the World Health Network, and I'm speaking on behalf of myself and as a patient and healthcare worker advocate. It is critical that HICPAC adopt guidance that fully acknowledges airborne transmission and its prevention, including masking with N95 respirators or better. There is no justification for adopting non-airborne precautions for airborne pathogens. I'm a type 1 diabetic and I'm unable to safely seek healthcare without universal masking in all healthcare environments. The disabled community was early to realize that COVID would endanger us. Research and lived experience have shown us that no one is safe. Young, old, disabled, abled, we are all at high risk from COVID-related disability and death. Not having universal masking guidance during an active airborne pandemic of a level 3 biohazard endangers all medical workers, their staff, their patients, all of their families, and the community at large. Clearly, there is enormous interest from the public and healthcare workers. I implore you to take action to protect us, offering appropriate protection, appropriate guidance for protection from airborne virus will have real impact. It will save lives and it will prevent disability. I implore you to take action. Please do your job. Please offer guidance that will protect us, that will save lives, and that will prevent further disability. Thank you.
Thank you. I'm going to turn it over to A. German.
I'm a health sciences student with a focus in public health. I'm also a medically vulnerable patient, and I've experienced healthcare-acquired infections myself, so I'll mainly speak from that perspective. But I'd like to emphasize that this issue affects everyone. Nobody should contract infections in medical settings, regardless of health status or whether they're a patient or a worker. All people deserve safe healthcare. We also deserve to have our voices heard in decisions that affect us. Public health policy must involve input from the public. Accessing necessary care for my chronic illnesses has grown unacceptably dangerous throughout the ongoing pandemic due to the lack of airborne transmission mitigations in healthcare settings. I've repeatedly been exposed to sick staff and patients who were wearing inadequate source control or were totally unmasked on the grounds that N95s are not required. And in some facilities, they don't even have N95s available on site since they're not standard PPE. The failure of public health agencies to emphasize the distinction between medical masks and respirators and their appropriate applications, especially that non-respirator masks are ineffective for aerosols such as SARS-CoV-2, has caused dangerous misinformation to be disseminated among healthcare workers that threatens both their safety and the safety of their patients. This false equivalency has resulted in them removing and replacing my respirator with a loose medical mask without consent, pathologizing me for trying to protect myself, and denying me ADA accommodations, among other adverse incidents. As a result, medical personnel infected me with a severe iatrogenic viral bronchitis that left me further disabled. That's why I'm still short of breath 2 years later. This is not the fault of individual staff. It is a systemic failure of leadership. They often cite CDC guidance to justify their lack of regard for PPE. In the last year, I have had to upgrade to an elastomeric to compensate for the rollback of universal masking policies in health settings. Requesting individual personnel to wear N95s is often met with refusal, has negative consequences on the provider-patient relationship, and is negated by other unmasked people present in the shared airspace. So I've had to ration crucial medical appointments due to the unreasonably high probability of catching COVID from my care team or from fellow patients. Right now, my mother and I are having to wear respirators and isolate in our own house because she took my grandmother to the hospital where there was no precautions in place. In the same way that patients should not be responsible for independently requesting contact precautions for touch-based pathogens, we should not have to beg healthcare staff to wear respirators so they don't infect us with airborne pathogens. It is unethical to place the onus of ensuring safety measures on patients, many of whom are unable to self-advocate. We should not have to fend for ourselves because of substandard guidelines that are not grounded in science. It is unacceptable to subject people to forced biohazard exposure through negligent standards of care and occupational safety. If HICPAC chooses not to instate universal N95 usage as the baseline, along with layered precautions as others will describe, it will only further impede medically vulnerable people's access to the care that we depend on to live, and will directly result in disabilities and deaths from preventable healthcare-acquired infections. You have the power to reduce the rates of morbidity and mortality from airborne infectious diseases if you so choose. Countless lives depend on you. Thank you for your time.
Thank you. I'm going to hand it over to Jennifer Maurer.
Hi, I'm so sorry about the background noise. Please let me know if you can't hear me. My name is Jennifer Mayer, and I'm a recent biology graduate from Case Western Reserve University. My parents are both healthcare workers. My mother is a primary care physician, and my father is an infectious disease specialist. A family member was hospitalized last winter, likely from enterovirus that caused neuroinflammation. It became immediately clear to me, a sentiment that was shared by my parents, that if my relative had a COVID infection during this time, they would have not survived. After reading the proposed guidelines or lack thereof, I am deeply concerned by the absence of prevention measures against airborne pathogens in hospitals, specifically the lack of N95 quality mask enforcement, air filtration, and ventilation, which puts everyone at risk. My relative was privileged. They have doctors in the family that are able to get them and all their family members Paxlovid and streamlined access to healthcare. It is horrendous to think that someone needs 2 family members that go through at least 4 years of medical school and 4 years of residency in order to barely survive under the circumstances that our healthcare system has created. Today, I want to emphasize air filtration and ventilation, specifically as it relates to future prevention. If the vast, large body of evidence that respirators and proper air filtration are extremely effective for controlling worker exposure to aerosols isn't enough, I'd like to provide another point, that as wildfires continue to rage across North America, forcing people indoors, everyone in those buildings, workers, medical professionals or not, and visitors, patients, relatives, or otherwise, will rely on this filtration. It is unbelievable to me that with the obvious looming climate crises, housing crisis, and continued healthcare crises over our heads, this lack of emphasis on prevention and preparation is not more of a concern. As healthcare issues compound from all of the things I just mentioned, healthcare collapses like those seen in the winters of this pandemic will only continue if left unaddressed. Please enforce mandatory N95 quality mask requirements and develop a thorough air filtration and ventilation plan for all hospitals. Please do your job. Please protect patients and lift the onus of having them advocate for themselves off their shoulders. Thank you.
Thank you so much. Handing it over to Amanda Farman.
Hi there, my name is Amanda and I'm a concerned citizen from Philadelphia. And I am scared to go to the doctor because of medical facilities are actively spreading and facilitating the spread of COVID due to not requiring respirators for staff and patients and not requiring proper air filtration. I have currently a variety of things that I need to go to the doctor for, and because they aren't life-threatening or urgent, I don't plan on going. I'm turning to try to figure out how to potentially treat them myself at home because I don't feel safe at the doctors. I feel that I would be at greater risk going to the doctors than letting these conditions go untreated due to the COVID risk. And this is just not okay. Guidelines for adopting effective prevention measures are absolutely necessary for the health of patients and healthcare workers. And policymakers need to prioritize risk reduction. They have a lot of power in this situation as far as having wide-ranging impacts in society. And infection control guidelines have to include experts in the field of airborne transmission, as well as those who are most at risk, patients and healthcare workers. These guidelines also have to include requiring N95 respirators, elastomeric respirators, and PAPRs. I don't understand how you can justify not requiring this in the position that you're in. Guidelines also have to include ventilation, HEPA air purification, masking, testing, and minimizing air sharing whenever possible. And we also have to include and communicate personal experiences in engaging with the healthcare system. Those who are at risk, which includes all patients, should be participating in the policymaking process. I don't want to be in a situation again where I'm arguing with a dentist about whether they're wearing a surgical mask is just as protective as them wearing an N95 mask when it comes to my risk for contracting COVID in a situation where I can't protect myself with a mask. The dentist in this situation backed their claim that they could just wear a surgical mask and that would be sufficient protection, with the fact that surgical ineffective masks are what the CDC recommends as far as COVID transmission. And this is ages ago. I don't even know if this would be the case now. Your policies have a direct impact on people's health and longevity, and I encourage you to make the right choice. Thank you.
Thank you. Sean Sprague.
Thank you. Hello, my name is Sean Sprague, and I'm commenting because at the present time, visiting a hospital or doctor's office to obtain medical treatment requires me to risk my health to do so, in part due to CDC's deficient guidance and protocols in the area of protection from aerosolized transmission of SARS-CoV-2. Although I am not currently disabled or a member of a high-risk population, I understand that SARS-CoV-2 is high risk for all people, including myself, given that even a single infection can alter the trajectory of one's life and health. In order to make medical facilities safe places for all Americans to visit, I ask that HICPAC and CDC advocate for standard and continuous usage of NIOSH-approved high-quality respirators, including N95s, elastomerics, and PAPRs, by all medical professionals. Also, HICPAC and CDC should clearly state that surgical masks are not sufficient to protect us from aerosolized pathogens, including SARS-CoV-2, that are now continuously spreading throughout the country, including asymptomatically. Surgical masks are not designed to provide a seal on the face and thereby allow unfiltered air to easily enter one's airways as well as escape via the loose edges of the mask. This is why we need to draw a clear dividing line between N95 respirators, which represent the minimum in true aerosolized protection, and masks below that standard, which are insufficient for aerosolized protection. Additionally, HICPAC and CDC should advocate for high standards of ventilation and air filtration, and make cleaning the air in all medical facilities its top priority for infectious disease control and prevention. I also wanted to take a moment to thank HICPAC for opening up the session on Tuesday to public comment. I greatly appreciated that, and my hope is that HICPAC will continue to increase transparency and openness in this process in the future as well. Thank you.
Thank you. Turning it over to Annalisa Schaefer.
Okay, sorry, here I am unmuted. My name is Annalisa Schaefer. Thank you for the opportunity to share my thoughts on this matter. My formal educational background is at Carnegie Mellon, and it is not in science, but like many, I owe my life to it. In 2015, I had a life-threatening kidney infection and was saved by medical science. Unfortunately, one of my kidneys is all but destroyed, so I am immunocompromised. From reading early 2020 news reports, I came to understand that due to this, I am high risk for severe disease and death from COVID-19. Therefore, I've been keeping up to date reading about it, and I am continuing to take layers of precautions to avoid it. My layers of precautions have evolved as improved, sorry, that's my under 2-year-old, I'm sorry. Improved information has been made available, from cloth masks and 6-foot distancing of 2020 to N95 respirators and HEPA filters in 2022. It is crucial that the CDC and HICPAC guidelines are up to date and shaped by incorporating input from a multidisciplinary set of scientific experts. Anything less is irresponsible. Prevention of viral spread is a complex task, and there is no shame, only pride in recruiting a variety of specialties to share in this important work. It is practically and morally correct to do everything possible to get this right. So much of the trauma and loss of 2020 was fueled by people not knowing what protections would work, worrying that effective protection was impossible, or taking what they thought were good precautions and getting sick anyway. So much ongoing suffering has resulted from uncertainty, lack of information, and untrue information. Belief in public health is being weakened by people doing what they're directed and getting poor results. As the saying goes, when we know better, we do better. I call upon this body to recognize aerosol transmission through inhalation of SARS-CoV-2 and other infectious aerosols, establish the highest infection prevention protocols for any proposed transmission by air category, ensure that updated guidance includes the use of multiple control measures, the Swiss cheese model, that have been shown to effectively prevent transmission of infectious aerosols. These include proper ventilation, air cleaning and filtering technology, isolation, respiratory protection, other personal protective equipment, PPE. Further, I want to urge HICPAC and CDC to slow down their update process and open up to effectively engage a wider variety of experts in developing drafts. These experts should include engineers, industrial hygienists, occupational health nurses, aerosol scientists, and experts in respiratory protection. We should not be listening to closest to MBAs and economists when it comes to health, safety, and science. I'll close by sharing that despite my tight-fitting N95 respirator, I am reluctant to seek healthcare because so few medical providers are masking. The ones who do almost always wear loose-fitting surgical masks. Why am I concerned about catching COVID in healthcare settings? Because I understand it's common now, and also I've witnessed the devastation myself. My parents got sick in March 2022 due to one-way masking. My dad was in and out of the hospital for a month. His Parkinson's symptoms have gotten way worse since his illness. He has never been the same since. People shouldn't have to face preventable infectious disease, unnecessary suffering, permanent impairment, and loss of quality of life when seeking healthcare. Thank you for your consideration.
Thank you so much. If you'll look in the chat, you'll see that Sharon has also posted how you can directly submit your written comments to HICPAC, HICPAC@cdc.gov. Direct them to Ms. Bird with the subject line isolation/infection control. I am at the end of the list of folks who signed up to speak. So if there's anyone else who would like to submit a comment, please do put your name in the chat so I can call on you. Otherwise, we'll look at wrapping this up. Okay, we've got a few more. Leora Madison, go ahead.
Hello, my name's Leora Madison. Recently, I made an appointment with my PCP about a condition related to the recent wildfire smoke. My PCP commented on my mask that we did not need to wear those anymore and that she had only been wearing her surgical mask since she had a cold. Now, the science has shown that surgical masks are not enough to prevent airborne transmission of viruses such as COVID. And this is something that should be communicated to doctors. I should not have to be communicating to my own doctor about this. I could try and switch to a different doctor. However, this is a systemic problem throughout the medical system, and it is difficult to find other doctors that know better. Currently, I have been wearing a P100 elastomeric to medical appointments, and this is not, and there are medical tests I need that would involve taking my masks off. I am not comfortable taking my masks off in medical settings anymore, so I hope HICPAC will communicate to doctors about the science on N95 or better level protection, so I could go to a doctor and have tests that involve taking my masks off. Thank you.
Thank you. Heather Sue Rosen.
Hi, can you hear me?
Yes, go ahead.
Thank you. My name is Heather Sue Rosen. I'm speaking as a medical sociologist and postdoctoral researcher at the New England Complex Systems Institute. I am also the child of 2 Air Force veterans, a resident of the state of Georgia, a member of the World Health Network, and a disabled person with an autoimmune disease and over 15 years of experience with medical gaslighting related to complex chronic illness. Some of these chronic illnesses put me at higher risk of complications from COVID-19, like juvenile idiopathic arthritis, asthma, Ehlers-Danlos syndrome, or EDS, type 3, and mast cell activation disorder, or MCAS. Others, like postural orthostatic tachycardia syndrome, or POTS, can arise after COVID-19 infection. Many long COVID patients have POTS. We are already ill-equipped to manage the onslaught of newly disabled patients with these illnesses, which were, as recently as 2019, considered rare, with some going as far as to question whether they were even real. Even now, with a growing population of people who are aware of POTS, long COVID patients complain of long wait times for appointments only to arrive and be referred to a psychiatrist before they receive any care. Allowing COVID-19 to spread unchecked in healthcare facilities exacerbates these difficulties. for people with complex chronic illnesses seeking healthcare. As more people will become ill with long COVID, a risk that increases with each subsequent infection. Healthcare workers are at inherently higher risk for infection with inadequate PPE, and many have left the workforce. Many people with long COVID have also dropped out of the workforce, including healthcare workers, but also across industries. Without protection against COVID-19 infection in healthcare, we are creating a situation that contributes to ongoing worker shortages, both in and outside of healthcare, while increasing the population of patients needing not just care, but specialized care. There are two main reasons it is not sufficient to limit respirator usage to certain areas of the hospital, clinic, or certain contexts of interactions. The first and most important is that SARS-CoV-2 is spread via infectious aerosols, which can linger in the air long after an infected person has left the space. Furthermore, surgical and procedural masks are insufficient protection against these infectious aerosols. N95 or better respirator masks must be required in healthcare and not limited to patient treatment areas. Because patients must wait in the waiting room amongst other patients, some of whom may be infectious. They must enter exam rooms shortly after other patients have left the space. COVID-19 may still be lingering. Lastly, some types of healthcare are performed in communal spaces. For example, physical therapist offices are often set up with several exam tables and various exercise equipment in one large open space. In my own visits to physical therapy since lifting the mask mandates, I have experienced hostility from clinic staff. Which leads me to the second reason. While fighting for safe and appropriate healthcare is not new to me, it definitely does not make me smile to see so many others that are now forced to do the same. As a sociologist, I have researched something called cultural health capital, which complex chronic illness patients do not have when they are not believed about their illnesses or their risk. I have a PhD and I am often not taken seriously until my white husband gets involved. It is naive to assume all patients considered high risk for severe acute phase COVID-19 will be able to successfully advocate for themselves so that their providers wear appropriate PPE during the exam, and that patients who achieve ADA accommodations are often still faced with providers in surgical or procedural masks instead of an N95 or better respirator. Healthcare is a human right, and healthcare providers took an oath to protect patients. I urge you to please protect us. Thank you.
Thank you, Heather Sue. I'm going to hand it over to Rosalie Bright.
Hi, good afternoon. I endorse all the above comments that have been made today and Tuesday at the HICPAC meeting. To summarize, standard and core practices for all patient care, not just those in isolation, should add these items. 1, air cleaning via ventilation and filtration. 2, universal N95 respirator use for all workers, not just those who have patient contact, visitors, and all possible patients. And 3, all workers, not just those who have patient contact, staying home on paid leave when symptomatic. Clean air helps not just with preventing infections, but also the performance, the cognitive performance of all workers, patients, and visitors, which is to be desired. I hold a Doctor of Science degree in epidemiology from Harvard. I have had a 31-year federal career as an epidemiologist at the Food and Drug Administration. When I was there, I saw much more transparent processes involving federal advisory committees and the benefits of patient representation in federal processes and advisory committees. I urge HICPAC to look at and investigate what FDA did regarding patient representation and how much to get the practical advice, and observe how much FDA feels it has benefited from patient involvement. There are several patient groups that HICPAC could contact to have representation on their committees. One of them being World Health Network, and others People CDC, and then there are a lot of local groups in the different states. Thank you for listening.
Thank you. I'm going to hand it over to Joy Bunton.
Give me 1 second. Sorry. I was typing this up last minute. Okay, I'm ready. Hi, my name is Joy Bunton in Chicago. I have polymyositis. a rare neuromuscular autoimmune disease which affects the proximal muscles. It later affected my lungs to the point where I have mild interstitial lung disease, which puts me at high risk along with other comorbidities. My rheumatologist told me when masking became optional, that optional didn't apply to me. He has heart disease. His father died at a young age of the same thing. So he said optional doesn't apply to him either. The last thing I expected was for masking mandates in healthcare facilities to be lifted, including hospitals and the dentists. I shouldn't have to explain to dental staff how I need everyone to wear a respiratory mask. The last thing I need is long COVID on top of the disability I currently have to affect my quality of life. It's hard enough navigating other public spaces where masks are optional. I don't need the unnecessary risk of getting long COVID in healthcare settings. Most long COVID patients started with a mild case, so classifying COVID as mild is medical malpractice. Only looking at hospitalizations and deaths isn't enough. Children are getting diabetes after getting COVID. COVID affects cognitive skills, yet masks are optional in schools. This needs to change. Hospitalizations are going back up. Aerosol experts have proven that respiratory masks are effective. This advice needs to be taken seriously as long COVID is a mass disabling event. Thank you.
Thank you, Joy. I'm going to hand it over to Sam Helper. And just a reminder, if you haven't spoken yet and you would like to comment, please put your name in the chat.
Thank you. I'd like to endorse all of the comments that we've heard thus far. I think it's very clear that there are many people throughout the community who have serious, legitimate concerns from a variety of perspectives. The only idea I would like to add is that HICPAC's guidelines and their focus on healthcare providers assessing their risk of exposure on a case-by-case basis also ignores the dynamics of this disease. There are a wide variety of studies indicating that a significant proportion, estimates vary, of COVID spread is from asymptomatic individuals. Moreover, reporting this summer has made it clear that the rapid antigen tests that most people use to determine whether or not they have COVID are very frequently inaccurate and provide false negatives. Under these circumstances, we have many people throughout our communities who sincerely believe that they do not have COVID. They may not have symptoms. They may even have tested and received a negative result. Under these circumstances, how are healthcare providers meant to assess their risk of exposure? It seems much more proper to assume that asymptomatic COVID may be present in any environment, particularly a high traffic area like healthcare, and to mask accordingly. Thank you.
Thank you so much. I see that we are again out of names in the chat. So I'm just gonna do one last call. Is there anybody who has not been able to make a comment yet who would like to? Please let us know in the chat. Okay, I think that everyone who wanted to was able to make a comment. I thank all of you for being here today.